So, welcome back to the Paediatric IBD Digest. I'm your host, Dr. Chris Bakewell, and I'm joined by my co-host, Dr. Tracy Coelho.
Dr. Bakewell, you look very nervous. Did you forget to prep for today's podcast? Or is it because we've got one of the big bosses joining us?
Yeah, you found me out, Tracy. I thought I was hiding it so well, but maybe it's because I've just finished a run of night shifts. I'm a little bit jaded as well. Yeah, welcome back, everyone. Today, we're exploring the topic of endoscopy and IBD. And the reason why I'm a little bit twitchy is that we've got a very special guest.
Indeed, and we are talking Olympus level here, demigod of endoscopy realm. Both of us were trained by this legend. So listeners, if you hear a tremble in our voices today, it's reverence, not fear.
Yeah, definitely reverence, but I would say maybe just a pinch of fear.
Of course, no doubt about that. And let's be honest, today's guest is as unfiltered as a double espresso. And this might be the perfect chance for you, Chris, to ask all the spicy, provocative questions that you have been bottling up for the last few years. How about that?
Yeah, well, thank you so much. I think better that you ask the tricky questions. What I'll do is what I always do, sit back, nod wisely, and pretend that I'm the humble co-host.
Dr. Bakewell, teamwork after all. Okay, I think we are a bit cryptic here. Maybe our listeners may be wondering, who's this towering intellect that has us both shaking in our smart casuals?
Yeah, so on today's podcast, we're going to be talking to our good friend and colleague, Dr. Nadeem Afzal.
The man, the myth, the scope-wielding legend. What a phenomenal personality. Honestly, I don't want to overdo the compliments. He might suddenly get suspicious of my overt display of sycophancy. But I really do believe he deserves all the accolades. Remind me, what's the best part you enjoyed about attending endoscopy list with Dr. Afzal?
Honestly, well, I mean, the most important thing, and speaking very genuinely, is how good an endoscopist he obviously was. When you first start training, it's difficult to know, but when you watch Nadeem's scope, it's very clear he is, expert level. You have some of these very difficult patients with very complex anatomy, and he just seemed to wind his way around with ease. And this is no offense to you, Tracy, as one of the people that trained me as well, but his lists were definitely the most fun to attend. You'd have music playing, Nadeem wielding his colonoscope like a lasso, and somehow with all that going on, the list finishing on time, even when I was scoping. So it must be some kind of miracle or his expertise.
No, I agree with you fully. So I haven't had a chance to join Dr. Afzal for ages. But if I did, what I would really look forward to is what I call the Afzal Samba. Ever heard of it?
Thankfully, I have no idea what you're talking about.
Okay, so picture this. Most endoscopists, when they hit a sharp bend, there's a lot of wrestling with the scope, back and forth, trying all sorts of maneuvers. But Dr. Afzal, when he hits that bend, something magical happens. His calm demeanor morphs into a smooth, rhythmic dance, hands moving like they are in perfect samba rhythm. And then, boom, he slides through that bend like it's a dance floor, glides effortlessly into the ilium, and you can see that satisfied grin spread across his face like he has just nailed the perfect choreography. And even the biopsy forceps seem to catch that samba fever, flying everywhere in joyful frenzy, like they're part of the performance.
Okay, folks, I think it's time to kick things off with Dr. Afzal. Let's start with a little something that Tracy would like to call Afzal Samba.
Samba, probably not. I'm pretty sure Dr. Afzal is a die-hard rock guy. So how about we swap to some rock and roll? A warm welcome to Dr. Afzal, the true legend of pediatric endoscopy. And if I may spice it up with a touch of Urdu, I would say the Shahin Shah of pediatric endoscopy. That's right. The king of kings, the emperor himself, gliding through the colons with the scopes.
Welcome, Dr. Afzal.
Good evening, both of yourselves and to the audience as well. I'm not so sure I deserve all those honorary titles you've conferred on me.
You surely do.
But thank you for having me. It's an absolute pleasure to be here.
That's really good to see you. We were just talking before we started recording, but since moving to King's, I've been feeling a bit of Afzal withdrawal. So thanks so much for coming on the pod, and especially for agreeing to share your wisdom on the topic today, which of course is endoscopy in IBD.
It's my pleasure. And well, look, I think we all know about pediatric endoscopy, but what little I know of and what we have particularly done over the last few years, I think I can certainly throw some light on it.
Dr. Afzal does not need any formal introduction, but for those of our listeners who may not know you, Nadeem, or Dr. Afzal, is Associate Professor of Pediatric Gastroenterology, Consultant in Paediatric Gastroenterology, Southampton Children's Hospital, and my esteemed colleague. Dr. Afzal has been my trainer previously, and yours too, Chris.
Indeed.
Was it a good experience?
Absolutely, yeah. You're about to find out.
Okay, thank you.
So, Dr. Afzal is a man of many talents. He loves cricket and he loves cameras, whether it is capturing stunning earthly landscapes or those sneaky little endoscopic cameras, getting an exclusive tour of the colonic scenery. And when he's not behind the lens, he's either playing cricket or busy shredding on his guitar. And if you're lucky today, we might just get a special performance from him at the end of the podcast. And I hear that he even makes guitars.
Thanks, Tracy. Yes, that is true. I think I started making in GCSE sort of level. So I think the first guitar I made was in Lahore, actually. So it was the whole thing was built from a book, and I wound my own pickups on. I'm not going to go into physics now. So there's how the sound is made and how it picks it up. So yeah, I did, and I've been doing it for many years. So we've made quite a few guitars now.
So is that kind of your side hustle at the moment?
No, I wouldn't call it a side hustle. We did raise some money for charity actually a few years ago for Southampton. I think it was a surgical ward. So a bit of charity and this and that, but no, there's no side hustle there.
Nice. So I had the opportunity to catch a glimpse of your heroic stance on the cricket pitch yesterday. Are you as much of a legend with the cricket bat as you are with the endoscope? I know that you've always been a great cricketer, but nowadays, is it mostly leg before wicket or still the legend before wicket?
I think it's seriously dwindled down in my senior years now. So many years ago, I did play first division for Sussex. It was a wonderful league, very competitive during my training years. And it was quite hard stuff because there's no margin of error. As you go higher level, there's absolutely no margin for error. I think it was with batting, it was just absolutely close your eyes and hit the ball. I'm more of a bowler, so it was more swing and pace.
It's interesting because my approach to colonoscopy for a number of months when I started was close your eyes and hope for the best. So there's clearly some parallels.
Yes, but you were supervised. You were supervised very closely. You may have felt like that, but we didn't let you.
So a few more warm-up questions before we talk about the endoscopy in IBD and all the other sciencey stuff. So a bit about yourself, preferably a non-PubMed version of yourself. So if you could give us a picture of your journey into pediatric gastroenterology, what drew you to the specialty and how your training has shaped that path? And how did life and career decisions eventually bring you to Southampton as a consultant?
So back in my junior doctor years, there weren't any structured rotations. So nowadays you will get a 2-year, 3-year rotation. So we had standalone jobs. So there were 6 month jobs, 1 year jobs. And immediately after my first post, I was lucky to get a post in Manchester Children's. So it was a rotation between peds neurology, then I did a bit of peds respiratory, burns, plastics, orthopedics, ENT. I did everything actually, including gastroenterology. And I think that's when I developed this interest in gastroenterology. There's always a peer, I think, who you tend to follow and you want to emulate. And I did find one or two people. I thought, oh yes, this looks great, I want to do this. But more so, I think I enjoyed the work of pediatric gastroenterology, and I got the flavor of doing gastroenterology. So I felt it was the right choice. And as events turned out, entering into training was a bit tricky. However, I got a research post first, which led to my doctorate at Queen Mary's. And then I got into the grid rotation. We used to have just one post advertised. So it was fairly competitive. But then after that, I think with Southampton, it was a no-brainer. I was quite lucky. There were a few options I had. Southampton was excellent. It was a growing unit. I knew Mark beforehand. And it also is a good combination and balance, I felt, for family life and cricket as well in Hampshire. So that I didn't think I would get in London, actually.
Yeah, I think, obviously having trained with you under you, Nadeem, I think one of the things that always resonated was when you talked about your experiences and the people that you trained with and under and eventually became peers with. It always seemed it was very important to you. And I think that's something that I took into my training, and to kind of, look at the people that you admire and see what it is they do and how they do it, and try and, learn from that. One of the things that I really wanted to ask you, and probably it's a good time to start with that, is, I hope you don't mind me saying, but certainly, from my perspective, you're one of the leading figures for pediatric endoscopy here in the UK. And as I have a role with trainees, and I'm very interested in the journey that you took specifically with your endoscopy training. Of course, because I train within the modern system, which is very formulaic and it's very itemized and reviewed, and there are certain criteria you have to meet. I suppose the structure and the exposure to training that you had might have been quite different. And I wondered just how that journey unfolded for you.
I think it comes from, because I followed a completely different path. My path started with research. So when I was doing my research, and with research, what happens is when you're doing a degree, I think Tracy has experienced this. Initially, it is slow to start off, and then work catches up, and then it really grows. And then in the final months, you're really, really, really trying to write and wrap things up. So when I started off, I wanted to do other things. And then Professor Mike Thompson, who has been my guru, actually, he's been very kind to me, and Martin Brewerton, he was based in Chelsea, actually. Two very wonderful people. They started me off. They started teaching me gastroscopy, and I was lucky. I was quite quick as well with it, and then moved on to do more scopes. And in those days, what used to happen was, if you were skilled, then you got options, or you got other facilities, or people wanted you to do their lists because you are sort of competent. And I think that sort of benefited me to have that launching pad to do that. And it wasn't that structured. You're absolutely right. So it was a bit of competitive, and it was a bit of, okay, you got it, you can do it, which wasn't really the right system. But that's how I entered. And I was quite fortunate, actually. What happened was, immediately after my research, I got the national number. In those days, that's what it was called, the grade. And when I entered, I was doing colonoscopies, actually. So when I started my clinical training, I was already doing colonoscopies. And that became even more easier, because when I started as a year 1 registrar, I was really doing year 3 stuff or year 4 stuff. And that enabled me to do more therapeutic work. The people I then got exposed to, as with any skill, it happens. Professor Nick Croft, Keith Lindley, John Fell, and I then developed my own method in the middle of this, because I had experience of working with all these wonderful gastroenterologists and very good endoscopists.
Thanks, Nadeem. It's great that you're giving credit to your mentors. Now, this may ruffle a few feathers, But is it possible that you may have inherited subconsciously some of their non-endoscopic quirks as well along the way?
I don't know. I think you can tell better, and Chris probably can tell better. Um, but certainly, I think the people who have influenced me, I think the most key person is Mike Thompson. We have done a lot of written work, published stuff, written book chapters. We've done lots of things, actually. And there are certain other things. Mike is very enterprising. I couldn't keep up with him, actually. So I couldn't do quite a few things he wanted to do as well. So Mike definitely takes the cake there. Then Nick is a very understated person, Professor Nick Croft. He has very different methods of scoping, and he learned from adults, and he's got very completely different style, actually. And I picked up quite a few tricks from him. For example, the ileoscopy, doing without a forceps, that was Nick. So he used different style. And then Rob Herschel, I used to get along very well, and he was absolutely fantastic when he was in Royal Free. Keith Lindley at Great Ormond Street. And the person who used to make me think, what am I doing? Because endoscopy, anybody can train to become an endoscopist, but to actually think what you are looking for, what you're doing, how to diagnose, that was Peter Miller, actually. So Peter Miller was, I would say, the Sherlock Holmes of pediatric gastroenterology. I think he taught me the thinking behind doing things, thinking about reasoning for doing things, and thinking about families and kids who are going to go through it. I think that's really, really, really crucial, actually.
That's brilliant. Nadeem, you have learned a lot from your mentors. Now, is it possible that they have learned something from the mentee, such as cricket, cameras, and other stuff?
I don't know. Definitely, I used to have access to a lot of software, which we couldn't have easy access to. So that was why my contribution. Um, 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 Taking from software, one other thing, I was quite keen trainee, so I used to see one of the readers actually in statistics in UCL. And he was absolutely brilliant. And I learned a lot of statistics from him. So I used to bring it back to the department from what I used to learn. So if you ask me theoretical knowledge about stats, I can't tell you any. But if you ask me to analyze something, I can give you the exact reasoning for it because I learned it from Richard Morris. I think he's got the chair now. He's probably in Bristol, I think, now. So I used to go to his office every week. I used to learn from him, and he was brilliant. So I don't know. They learned anything from me.
Yeah, I'm sure they did. Okay, so you served as chair of the Paediatric Endoscopy Working Group at Basbagan, British Society of Paediatric Gastroenterology, Hepatology and Nutrition from 2021 to 2024, during which you played a big role in developing the Pediatric Global Rating Scale, PGRS, for endoscopy. And I understand this is still work in progress. And the amount of work which has gone into this from your end is phenomenal. Now, this is a very long question with sub-questions. Could you share with us what the PGRS aims to achieve, how it aligns or differs from the adult GRS, and do you believe that the training requirements for pediatric endoscopists should be different from those in the adult practice?
That's almost a 3 or 4-parter question, actually.
That is a classic, Tracy. Bear in mind that all of the questions will be 4 parts. So,
okay. Let's start with the PGRS. Well, what is PGRS? Well, PGRS is a quality improvement tool that provides a framework for pediatric endoscopy service improvement. So it's a tool with which you hope to improve service, and then with this tool, hopefully you can then benchmark against the national standard. So hence upskill what you're doing in your own units. So the first thing is, the good news is it's done. I think it was out for feedback as well. That process has been completed. We have a launch date. And the launch date is the day when I'm doing endoscopy on the 10th of July, which you are kindly covering as well. So the PGRS is going to be out. and this is actually the second version of the PGRS. This was a lot. There was a lot of work has gone into it, and it's been made possible by the excellent, fantastic endoscopy working group members. I was very fortunate to collaborate with dedicated colleagues throughout across the UK, actually, from north to south. And I think it was again the two-way process. It was their energy. It was about their flexibility. So when we started this work, it was COVID epidemic was on. And basically we did lots of team meetings, but more so people were readily available to develop this because everybody was excited. And as I said, to make things happen, you need two hands to clap. And I think it was more them rather than me who actually pushed it. And we just went through everything. We had several meetings. And then they had amazing insight. And I had the benefit of then having insight from what happens in the north, what happens in Midlands, what happens in the south, and that sort of thing. And it became a productive and quite an enjoyable process. I think our biggest challenge was to create a tool that recognizes excellent practice in all the units, but encompasses all the units. So, if you look at endoscopy services, you've got different types of units. You've got standalone children's hospitals, you've got joint up with adult services, then it's carried out by surgeons, then it's carried out in the private sector as well, and then it's carried out in some district hospitals as well by some really excellent endoscopists, actually. And the real key here was not to shortchange anyone, but actually these are sort of standards which can be adopted to anyone who is using in their service and in their practice. And that, I think, was the massive challenge. There were a few other things we addressed. I think, for example, one of the most key bit was there's a significant gap in endoscopy service for the 16 to 18-year-olds. And I find actually in some places, and I've heard some stories, that a 17-year-old is a nowhere land almost. I call that twilight zone. So 16 pediatrics says, okay, we are finished. We are not going to endoscope a 17-year-old. Adults say, oh, actually, we're not going to start till they're 18-year-old. So where does the poor 17-year-old go? And we have addressed that in this as well, that it really doesn't matter who does provide the service, whether it's pediatrics or adults, but there needs to be a service provision. So it's things like these. We have tried to bring it up to date, and we tried to encompass that in the whole quality improvement tool. Now, I think the other thing you asked me was the differences from adults. So first thing is, there's a lot of commonality with adults. So the safety, quality, and communication, all of that, and providing good quality of endoscopy is the ethos is the same, whether you do adults or whether you do pediatrics. And we've tried to keep the theme same. We've tried to keep the style the same, but it's very pediatric oriented, this bit. The differences, however, are there, and they're quite significant differences, as you would see in pediatric practice compared to an adult medical practice. In endoscopy, you're starting with consent, so that's different. More focus on therapeutic endoscopy in adults. You're diagnosing cancer, you're doing screening for cancer. Whereas in children, you're doing more diagnostic work. So all of this is important. The other important thing which does impact on training is, if you look at volumes of scopes being done, adults do a huge volume of scopes in compared to us. And then in that remit, then we have to offer training. Some units are doing even less, and some units are doing more. We are quite a busy center, and we can provide those numbers and provide the training. So there are limitations with that as well. So there are a fair few differences, but the general ethos of adult practice is the same as pediatric endoscopy.
And it was we said it before, but it was a huge amount of work, Nadeem. And I think that I hope you get, you and the endoscopy working group get the recognition for that, because it seems trivial, right, to recreate guidelines for pediatrics, but actually what it's doing is it's priority setting for a very specific group and highlighting where there are similarities, but as importantly, highlighting where there are differences and bringing it into the light so people are aware of what the challenges are to make sure children are prioritized, especially, as you said, that kind of no man's land in some centres between 16 and 18. But I think it can only be a good thing, and I think that should be really celebrated, and hopefully it will be.
Thank you, Chris. I think the key thing here is for us, it wasn't a tick box exercise because we already had a PGRS1 and it had to be different. So I think the main key was to bring out the pediatrics bit. And one of the best things I heard, both from JAG's side and some from quite a few reviewers as well, and the main sentence which made my day, or our endoscopy working group day, was, "This looks like pediatrics. This is for pediatrics." So it's not meant to be a tick box form or a tick box exercise, which sometimes these things feel like, but it's actually, hopefully it's going to make a difference because it has got all those elements which were sort of more covered in this second version.
Okay, so before we get stuck into the juicy bits of endoscopy in IBD, I wanted to take a moment to set the scene, especially for listeners who may not be totally sure what endoscopy actually involves when it comes to Crohn's and colitis. Now, a full disclosure, this might be a bit of a monologue, but Dr. Afzal, because you have been my endoscopy trainer, I would be expecting you to mark me on this. And just remember, if I get it wrong, I will be blaming the trainer, not the trainee. That seems to be the trend nowadays. When in doubt, just blame the trainer. Though my co-host, Dr. Bakewell, who is only just finishing the training, might find this one a bit hard to digest.
No, I'm happy to blame you for any of my problems. It's fine.
So an upper GI endoscopy and colonoscopy are essential parts of the diagnostic process, which allows us to directly examine the lining of the GI tract, take biopsies, look for telltale features which help distinguish between Crohn's and colitis. Now, Crohn's can pop up anywhere from the mouth to the anus, and its endoscopic footprint is a bit of a patchy puzzle. Skip lesions are classic, patches of inflammation or sores separated by normal lining of the mucosa. Now, ulcerative colitis is limited to the colon. The inflammation tends to be continuous, starts in the rectum, extends upwards in a continuous pattern, redness, ulcers, pus, bleeding on contact. In children, it's often extensive, which means it can involve the whole colon, what we call pancolitis. Typically, the small bowel is not affected, although it can show signs of irritation, what we call backwash ileitis. Now, for a long time, I struggled to understand this concept of backwash ileitis. And if my monologue is still tolerable and not too long, I will share my analogy with regards to backwash ileitis. Is that okay?
Stunned silence, I think. Go on, please.
Yeah, okay. So ulcerative colitis is like a wild beach party, which is inflammation, that's supposed to happen only along the colonic shoreline. Normally, the small intestine, especially in the ileum, is the quieter part of the beach, peaceful and untouched. Outside the party zone, sorry, I'm using this beach analogy because I come from Goa, which is very seaside. But in backwash ileitis, it is as if the tide of inflammation gets too wild, and after the beach party ends in the colon, some of the dirty foam trash, which is inflammation, gets carried back by the tide, washes up on the clean edge of the small intestine, which is a terminal ileum. Dr. Afzal, have you fallen asleep?
Yes, Tracy. I must say, I've never seen gastroenterology in this poetic way, actually. Very good.
There's a party in your colon is an interesting way to describe UC, but I like it.
Thank you.
Right. One of the things that I did want to talk about, which I guess, we have a broad listenership, but many jobbing gastroenterologists. So one thing that maybe everyone, but certainly more junior colleagues might find challenging in day-to-day practice is around endoscopy in the very acute IBD settings. So, for example, a child with suspected acute severe colitis or someone not yet diagnosed with IBD, but with these severe symptoms. Limited colonoscopy is often considered before starting on immunosuppressive treatment for very good reasons. But I just wondered, Nadeem, if you could talk us through when you might opt specifically for a limited procedure rather than going to a full ileoscopy. And if you're committing to a scope, what are the signs that you're seeing when you're doing the colonoscopy that would suggest, actually, no, this is sufficient now, we need to stop?
Okay. First of all, the principle to do scope. It's not very complex. So the diagnostic procedures need to be done safely. So if you're taking somebody's appendix out, there's a risk with all that, but you got to finish the job till you take the appendix out. Whereas with diagnostic things, you don't necessarily have to reach the ileum. You can, do a limited scope, and I think that's fine. But the main thing I think is it shouldn't be because of skill limitation. So sometimes people would do a limited scope because they can't look beyond certain area because it's hard to go around and stuff. I think it's going to be individual, but the idea would be that people can do scopes, and the expected standard, which has been laid out now, is that 85% of the children do have an ileoscopy. That's at least a requirement in the training. Now, we diagnose about over 100 IBD cases over a year, in a year, and that has been our rate for the last few years. And even in very sick kids, including our ileoscopy rate is 85%. That's our audit figures as we do annually, including the last year. And I presented in BUSP again before year as well. In cases of, certainly in severe inflammation, if you're doing a scope, I think the key things is, based on what you can do, is to avoid certain things. And I tend to avoid, for example, abdominal pressure. Hopefully, Tracy and yourself have noticed. So in a sick IBD, I would never, ever put abdominal pressure. So that's the first thing. Second, I focus a lot on de-looping, even at the very early stage, so that there's minimal loops to encounter. If I feel there's any loop, and I've done it sufficiently for a few years, I can feel there's a loop coming, then I will not push. So it has to be without pressure. It has to be, I was taught it has to be 2 fingers holding the colonoscope, and there shouldn't be any pressure. You should just advance it like that. So avoiding pressure, and certainly if you can see that's going to happen, then don't please proceed. It's not worth the risk. Now, when the bowel is actively bleeding, or if it's friable, especially a kid who may have presented, and we saw some of these kids in COVID who for various reasons presented quite late. They were almost pre-surgical, and certainly 1 or 2 almost lost their bowels because they were not responsive to absolutely any treatment within 10 days of presentation. So they would have a limited scope because you're otherwise going in and you're putting them at risk for perforation. And this child is already nutritionally very compromised. So you don't want to do that. It is, I think, important that actually we have KPI and skill-based training so that all endoscopists have a safe, competent standard. And that has been the whole exercise of producing this training document and all this PGRS and everything, so that actually you are able to do a full scope, but actually there are clear, valid reasons for limitation of your scope.
And I think maybe perhaps these questions are then the wrong way around, but the other part of that decision making is the timing of that endoscopy, because of course you've got this sick kid. You could scope straight away on CPOD, or you could leave it 1 week, 2 weeks, or longer if you felt needed. In your experience, does that timing of the endoscopy impact the overall management of these cases? Would there be a risk in treating them empirically or delaying their endoscopy till they're nutritionally a bit more optimized?
Yeah, it's a hard question, actually. I think, as you rightly say, the clinical context really matters here. I would like to get the diagnosis before starting treatment. That's what I tend to do. And I will often arrange even an urgent scope, even if it has to be an emergency based. I think that's justified. But I think if the child is very unwell, the example I gave just in previously, and then I would occasionally have even done treatment before proceeding to endoscopy. Now, with regards to doing an endoscopy a couple of weeks later, if the child is significantly better, I wouldn't put them through a scope. There's absolutely no point. And it's not a tick box exercise. It's really a diagnostic process. Only if they're not getting better, then I would probably do a limited scope, particularly to see inflammatory bowel, and also to exclude things like CMV. And there's no infection, concurrent infection, which requires or is making things worse. Now, the important thing here is that somebody who has not had a scope, or I don't fully understand and I've treated them, I would never ever put them on long-term standard therapies. So they would never have a biologic without solid evidence. They would never have azathioprine or any of the immunosuppressants in the long run. And I think escalation to immunosuppression should be very firm evidence-based diagnosis, not just based on clinical suspicion. So I think it's a hard question. It does come down to individual decision, and it does come down to how the child has presented and how you're going to safely proceed with it. So I don't think there's a wrong or right answer, but the right answer perhaps is doing it safely.
Great. So obviously the first part of that was talking very much about the acute severe IBD, whether that's Crohn's or colitis. I think now let's move on a little bit to more the routine endoscopy in children with maybe already established IBD who have started treatment, who are doing really well. What's your approach to that reassessment endoscopy after treatment, for example, with a biologic? Is it always necessary, or can we be a bit more selective, especially given the pressures that we have? You talked about how many patients we're diagnosing, and in this series we've talked about the increasing incidence and prevalence of IBD.
So I have not let endoscopy list pressures to dictate what is needed for a certain child ever. It has sometimes meant that somebody who's booked routinely gets cancelled and postponed. But somebody who does need it, I've never tried to compromise in my practice, actually. Now, 15, 20 years ago, or at least when I was training, we didn't have fecal calprotectin. I think that's a brilliant biomarker. So fecal calprotectin has become routine now. And I think with that, our number of scopes has gone down. I think it's a wonderful, wonderful tool to use for monitoring inflammatory bowel. In the days when I was training, we were doing pre-enteral nutrition, post-enteral nutrition scope. And then we were doing more scopes to monitor even before azathioprine, after azathioprine, and et cetera, et cetera, et cetera. None of it is needed anymore. However, saying all this, there are exceptions. So the first thing I want to say is when you're assessing and the anastomosis site post-surgery, then you definitely need a scope, because you need to see if there's any inflammation at the anastomotic site, which requires management, treatment, escalation of treatment. So that's one thing is a given. They all have a scope within 3 to 6 months after a join-up surgery. The second thing where I think it is important is to look for strictures. So there's sometimes children have bowel symptoms or inflammatory bowel-like symptoms, but actually they're having symptoms not because of inflammation, but because of narrowing. So in those cases where I can't explain it just by calprotectin, I would definitely scope them and to see if there's any narrowing or strictures. And if necessary, I will do further imaging to assist it. So, because really, if it's a fibrotic stricture, if it's very limited, you perhaps could consider dilatation, but otherwise it requires surgery.
Yeah, it's a really good point. I mean, that calprotectin thing is so important, right? It's just such a shame that in our population, bringing a poo to clinic is such a difficult thing, because of course it's so helpful to have that number, but it's understandable that when you're 16, you don't really want to bring a stool sample to your clinic appointment. So I don't know, it always feels like there's some work to be done there in order to help that process. And I think in COVID there was lots of home testing kits and things trialed.
That's absolutely true. Now, one of my observations from Dr. Afzal's clinic is that patients may not always get poo specimens, but they often get chocolates for Dr. Afzal. Is that true, Dr. Afzal?
No, not really. But no, but I just wanted to make a comment on that. So in COVID, we set up a home calprotectin service. So um, uh, I engaged in discussion with um, calprotectin testing companies, which are very good actually. But then I spoke to certain families that, particularly in our area, they found it tricky to do because there's a lot of processing and chemicals you need to add and need to sit for 3 hours and that sort of thing, and they couldn't do it. So therefore, I spoke to our lab, and they trust the ELISA technique to analyze calprotectin. So therefore, what happened was we set up a postal service. I think we put an abstract in Aspergan as well, actually. So we give self. It's a stamped envelope with address on it, which goes directly to immunology, and who can be posted through Royal Mail, which is an excellent way which people can do in their comfort zone. And I do find actually our success rate of getting stool specimens back is much higher. It's not 100%, but it's much better than, Chris, you're right, embarrassingly bringing a poo specimen to the appointment and then start talking about your bowel, which can be tricky actually.
Okay. A very similar question to the one we asked previously with regards to routine endoscopy. Now, before transitioning patients to adult care, in the past, I remember when I was training, that used to be the norm, but nowadays we have also reduced doing reassessment endoscopies before transitioning their care. Would that be fair to say?
I think if we are nearing transition, then I think we sometimes do, not in all cases though. So quite often at this stage, some are finished their GCSEs, some are there still in A levels, and some are going to do A levels in the subsequent year. So I still use the same indication actually. I don't do it because they're 17. I don't do it because somebody's 15, 10. So I will do it if they need it. Now, we would consider doing endoscopy before stoppage of treatment. And I noticed when I was doing some work in Europe as well, that actually we are one of the very rare centers to even stop treatment or consider stop treatment in teenagers. And I have done that in quite a few kids. And then because we have got such a nice transition service, it seems to seamlessly be taken over by adult services, not just in Southampton, but we have got some very good transition links throughout the region. In local district hospitals, where we dialogue with the specialist nurses, and quite often the gastroenterology, adult gastroenterology colleagues and ourselves, we know each other. So which works really, really well. So in a way, it becomes seamless. And I just find actually that the service should be seamless. A person shouldn't receive an endoscopy because it's a tick box exercise, but I think it should be more because they clinically need it, and you're going to do something with it, and then you do it. There are quite a few kids. I've just done a transition clinic. We transitioned 6, and I think none of them probably had an endoscopy actually this year.
That's brilliant. Thank you. So, 2 areas which we don't often hear about in pediatric endoscopy. One is green endoscopy, and the other concept is ergonomics for the endoscopist. What are your thoughts on these 2 concepts? Is there any traction in pediatrics, and how should we be going forward with that?
Yeah, I think I've got my own view on all this. First of all, green endoscopy is very much part of what's going to happen in coming years. And when we think of green endoscopy, we talk about green endoscopy and ergonomics. It's all about reducing waste. I'll be very honest with you, as a gastroenterologist, I do not understand that whatsoever. And I think that's within the remit of people who understand that, and to calculate for us and tell us where we can save CO2 and we can reduce the carbon load. I think for us endoscopists, there's a very straight way forward. If you look at the Dr. Foster's reports, and there is considerable variation across centers in diagnostic rates. And I think for us as a gastroenterologist and a pediatric gastroenterologist, I think green endoscopy has to start with reducing unnecessary or normal procedures. So if you're doing a lot of normal procedures and the proportion is really disproportionately high, there's something wrong in the service. And we know there's a mismatch with Dr. Foster's reports throughout the Britain. So I think to me, green endoscopy is about reducing unnecessary procedures or very normal procedures. And then, of course, with it comes promoting a more sustainable, equitable, and evidence-based approach. I think we should be joined up on indications for doing endoscopy. I think that should be universal. That was some of the work we were going to do, and that was project number 6 for us. We didn't have time for it. And that was on our agenda. We just couldn't do it, actually, during my time. But that's, I think, I see as green. It's about reducing unnecessary scopes as a pediatric gastroenterologist. And that's, I think, our responsibility. And why put a poor child through a procedure if they don't need it?
Well said.
Any thoughts on underwater endoscopy? I know in the adult world they do it a lot.
Yeah, I think the underwater endoscopy is not new, first of all. It's been done for the last 2 decades or more. And I think it's about learning the technique and using water, which, despite being used in the adult world for 2.5 decades, is not taken over by pediatrics. I'm not aware of any pediatric centers in Britain. There's probably the odd center in the world who's probably using it. People say that it helps to clear the lining better, to look at cancers, even picking up diverticulitis, because you can see bubbles going through diverticuli, which we never will see in pediatrics. So I think I will watch the space, look for evidence before we adopt it. And I think even if we use it, I think there's going to be a learning curve to it. It's not going to be simplistic. So I think I don't see any immediate applications of it, but where to be proven wrong.
Yeah, maybe there might be the odd person sort of half using it, I suppose, weighing down part of the colon just to get round a bend, rather than the true principle of pure underwater endoscopy, which I think is probably quite different in adult world. Like you say, if in terms of the diagnostic capabilities, looking at that mucosal lining a bit more clearly. So as we come to the end of the episode, which maybe you'll be glad to know, I don't know, let's look a bit to the future, if that's okay. Dr. Afzal, I think it's fair to say, so everyone that knows you, you're clearly an early adopter of technology. Anyone that's been in your office will see that. Your very nice microphone and keyboard. With that in mind, where do you see the role of endoscopy evolving, specifically thinking about the management of pediatric IBD? Is there anything on the horizon that we haven't talked about today? I guess what we're really talking about is that concept of AI that they're using in adult endoscopy, certainly for that surveillance of, lesion detection. Do you see technologies like that coming into pediatrics? And what impact do you think they might have?
Yeah, so the adults are definitely using some software, AI software. And for example, I'm heard of the GI Genius and CAD-EYE, and there's a few more, I think. And they are for polyp and early cancer detection. I think AI is also being used by capsule, Tracy, is that correct?
Yeah, that's correct, yeah.
So I think it's to identify lesions and pick up lesions. The problem with AI, however, is you got to tweak the sensitivity. And you can end up doing either overdiagnosis or underdiagnosis because AI, at the end of the day, is a program, and it will do what you tell it to do. So, and that caveat exists. So I think they always see there is going to be a human element to this. As much as AI we have, there's going to be still a human element to all this, actually. Now in pediatrics, we don't deal with cancer. We're lucky. And I think AI in pediatrics endoscopy is very, very, very early stages. I think the odd unit, just for their reasons, have used it. But I think the space is still to develop. I think AI tools could highlight suspicious lesions for us, I think, and do it in real time. So when I'm scoping, they say, oh, ping, yeah, that looks strange. What is it? And then the sensitivity has to be adjusted, of course, and AI has got the ability to learn with time as well. I think that sort of thing might be there. And then, of course, when we biopsy, now lot of inflammatory conditions tend to be patchy. I think, Tracy, you said it just now. And when you're dealing with patchy lesions, I wouldn't mind AI telling me, oh yeah, biopsy this area. Or somebody who's training or doesn't recognize lesions, biopsy this area. Or even if there's some sort of confocal microscopy or something clever attached to the scope which can magnify it, and AI picks it up and say, and I'm looking at the lining, it looks normal to me. It says, no, this looks abnormal. And AI identifies, and then I take a piece out of there. And I think that will be quite clever, actually.
Yeah, those subtle lesions that maybe as you're focusing on getting around the colon or lots of other things you have to focus on, maybe as an additional tool.
Absolutely. And I think in IBD, there's going to be more uses. I'm not going to jump into that. I'm going to stick to endoscopy. But in IBD, I think there are going to be more models and stuff people will come up with where you can put all the parameters at diagnosis and come out with an algorithm. Again, that will be dictated by AI and based on protocols. That will still have to be individualized. But I think with AI, you could get individualized and more consistent treatment across the board. With people doing more the same thing rather than different things in different units.
Well, as the early adopter, we'll be looking to you, Nadeem. You've got to bring it in.
I think it's your generation who's going to do it.
Yeah, okay. Fine. Perfect. Thank you so much for that. So as we're closing then, Nadeem, Dr. Afzal, any final thoughts for our listeners about endoscopy and IBD?
Okay. First of all, for my endoscopy colleagues and those in training, I hope you find the PGRS and training criteria for colonoscopy useful. We really hope at EWG, the group we produced it with, that it's going to help things and do good things in our practices. Another head up for the trainees, we're going to have a dedicated online pediatric endoscopy training course. That's almost happened. We are at the final stages of that, so watch the space. We should hear in the next few months for that. For listeners who have experienced pediatric endoscopy themselves or for their children, when you go through procedures, please ask the endoscopist, ask questions, definitely clarify the purpose of the procedure. And if you don't have any understanding, ask. We encourage families to ask as many questions as they want to ask. All procedures carry a risk. Pediatric endoscopy, fortunately, has a low complication rate. If you're doing therapeutic procedures, it's a little bit raised. And it's always worth addressing any concerns beforehand. And that was my little final thoughts. And thank you for having me on the show.
Thank you. We've had a great discussion. So as the tradition goes, do we have time for a few poetic rhymes, Dr. Afzal?
Okay, I'm open to listening. Or is it from yourself, Dr. Coelho?
Yeah, you're welcome to spit a verse or two, or you know.
My poems are limited to ChatGPT version 4.
Dr. Coelho is adamant that his don't come from ChatGPT, and don't you dare accuse it of coming from.
Yes, I know. I'm aware he's a natural poet.
Thank you, Dr. Afzal. That's very kind. And I'm really flattered by the unwavering trust my co-host has in my poetic abilities. Anyway, the standard disclaimer that this poem is fictional and does not bear resemblance to any specific trainee or trainer. So here we go. The name of the poem, The Scopic Odyssey. As the keen learner, seemingly breezing through, gets stuck at the treacherous bend, despite all shared tricks of scoping wisdom from the attending, didactic but a daunting friend, yet the loopy tangles of scopes at the play of the inexperienced hand, bouncing back and forth, seem so tricky and ever so hard to mend. With not an awful lot of theatre time to spend, training or whatever, theatre stuff will not care to understand. And so, Daddy Moses now takes over, the scope now subtly enmeshed in the cathartic fecal blend, and off it glides to the ileum, the scoper's promised land. In despair with achy hands, the lowly trainee voice wished they could make amends. The trainer, careful though, lest he spews out a dops that brutally offends. But deep within lurks the hearty grin. It's just experience, my friends. Thank you.
Thank you, Tracy.
Very good. It felt very personal at times, Tracy. Was that?
Yes.
No, as the disclaimer goes, nothing personal. Anyway, Dr. Afzal, it's been a great pleasure having you on the podcast. Thank you so much.
Thank you very much for having me. I really enjoyed. Thank you very much.
And just as promised, here he is, Dr. Afzal, rocking the guitar. Please excuse my musical knowledge, but this piece is in D minor, pentatonic, with a loose, improvised feel and a hint of Hendrix style phrasing in it. This is Dr. Afzal's favorite guitar, all hand-built by Dr. Afzal himself. And it's indeed a marvelous play. Enjoy.
Wow. Thanks so much, Nadeem. That was really special. And thank you to our listeners of the Paediatric IBD podcast. Thanks for tuning in, and do come back for the next episode.